Good morning and welcome you for the online anesthesia postgraduate teaching program on Zoom platform sponsored by Aquila and hosted by J.EDWARD and simultaneously aired by Anaesthesia TV. Today we are hosting the last session of critical care series. Today's the first topic is the basics of echo, what anesthesiologists should know. It is a part 2. Part 1 is already presented by Dr. Raajesh 3 months back. And he is working as a professor and in the Department of Anaesthesiology, and he is the in-charge medical superintendent of Indira Gandhi Medical College and Research Institute called Puducherry. He has conducted many workshops on echo and he invited faculty for guest lectures for many conferences and CME. He has published more than 15 articles in the reputed journals. We welcome you, sir, on behalf of Online Anesthesia. Over to you, sir.
Very good morning, sir. I'm very happy and feel privileged to be part of this fantastic team. And as I said, can I share my slides, sir? Is it visible, sir? Is it visible?
Yes.
Yeah, I'll just go on this slideshow. Okay.
Yes.
Very good morning, all the viewers. It's Sunday morning. Very happy that a lot of people have logged in. So as we go to our second session, so before that, let's see what is our whatever we have seen in the previous session. Short recap. So what we have seen in the last session is how to image the heart. What do you mean by different windows? And in each windows, what are the structures you are going to see and the importance of those structures. And also at the end, we have seen how to analyze the systolic function. So the advantages of eyeballing technique and the assessment of systolic function. This is what we have seen in the first session. So as we move on to our next session, so we need to know as an anesthetist, what are all the other things? What information we can get from this bedside echo. It's not a comprehensive evaluation of the echocardiogram, as you know. So with the bedside tool, as a echocardiogram as a bedside tool, what are we going to do? Start with the diastolic function, and then we'll move on to the right ventricular function, how to assess. Then identification of significant valvular lesions, especially the stenotic lesions. And most importantly, what are all the regional wall motion abnormalities and how to pick up them. And the calculation of the stroke volume, which will be very important if you are taking care of the ICU patients also. And finally, put together whatever information we have collected over these 2 sessions, how to put it together or how to approach a patient when the patient is very unstable. Okay, so with that introduction, we'll start our today's topic. Okay. So we'll start with the assessment of diastolic function. So we know that the importance what we give for assessment of the systolic function, we don't give much information or importance to the diastolic function, but that's very wrong. Because the impact of diastolic dysfunction in anesthesia and critical care is a well-established one. So in what way it is going to help us? So it has been clearly proven beyond doubt that it is one of the independent preoperative risk factor for the development of the postoperative pulmonary complications, especially pulmonary edema. And also it can, if it is not managed properly, it can cause heart failure, postoperative worsening of the systolic function. So that we can, if you know that particularly about the patients who have diastolic dysfunction, you can stratify the risk. Especially, you need to optimize their fluid administration. That is the perioperative side. And also, it is considered as one of the indicator, the risk factor for the difficult to wean patients. So in the ICU, clearly studies have shown that diastolic dysfunction is one of the criteria we have to take care while we feel or while we come across a difficult to wean patients. So how we are going to assess the diastolic function. That's what is next 5 or 6 slides I'm going to work on. As you know, the diastolic phase starts from closure of the aortic valve to the closure of the mitral valve. So what happens immediately after the closure of the aortic valve? So there is a period in which both aortic valve and the mitral valves are in closed position. So during that time, the LV starts relaxing, but still mitral valve is not opened. So as a result, there is something like a small or a small negative pressure is getting developed in the LV. So this period is called isovolumetric relaxation phase. And this is characterized by what is known as IVRT, isovolumetric relaxation time. So when this pressure goes down a little bit below your left atrial pressure, what happens? The mitral valve opens. So as a result, there is a gush of fluid. So once this blood. So when this blood reaches the LV pressure also starts rising. At some point of the time, the pressure gets equalized. So the flow from the LA goes down, and there will be a short period of no flow or a low flow. Then again, whatever the remaining, the blood which is present in the left atrium, because of the active contraction of the atrium, the remaining blood is entering into the LV. So this is the schematic representation of this E and A wave, early wave and also the atrium. So in case if you are able to analyze the velocity of this wave, these two waves, then we will be able to identify the diastolic function. This is the concept. Okay. So how are we going to? The comprehensive echo deals with so many patterns, your mitral inflow patterns, that annular systolic velocity assessment, LA volume, pulmonary or hepatic venous return. But as a bedside tool, we are concentrating only on these two parameters. The one is mitral inflow patterns. As the name suggests, we are going to analyze the inflow at the mitral valve so that we get these two waves, E and A. Then we have different time intervals. Then we analyze that. Then what is called as the mitral annular systolic velocity. So I'll talk about little later. Then this E dash and E ratio, E and E dash ratio. So based on these parameters, we can assess our diastolic dysfunction. So how are we going to do that? So by this time, you know that what is this view? It's a apical 4-chamber view. And this is a mitral valve, and this is LV, this is LV. So if it is possible to analyze the velocity of the mitral inflow, that is from the LA, once the mitral valve is entering into the LV, if we can analyze the mitral inflow velocities here, because the diastolic function is the interplay between the pressure changes between the LV and LA during the diastolic time. So if we can analyze the velocity here, then we'll be able to address, or we will be able to know about the diastolic function of the heart. That's the left ventricle. That is our concept. Okay. So to do that, what we should know? We know that Doppler is employed to assess or analyze the velocity studies. So we have two different types of Doppler. One is the pulse wave Doppler. The other one is the continuous wave Doppler. And we know that if you want to study the Doppler at one particular area, then we should employ the pulse wave Doppler. But the limitation is it can analyze only the limited velocity. So if the velocity increases, then we have to go for the continuous wave Doppler. So for mitral inflow patterns, we need to use the pulse wave Doppler. So you place the pulse wave sample volume here in this, as I told, exactly in this place, just above the mitral valve, this opening of the mitral valve, you get these type of waves. So the first wave is the E wave, the second wave is the A wave. So then using the caliper, the calculation package, you can go to that, you can select, you can assess the E wave and A wave. So you will get the ratio of E by A. How to interpret that? I'll come to that little later. The second thing is our annular systolic velocity. So here we are not analyzing the velocity of the blood flow. Here we are analyzing the velocity of the tissue. That is the annulus of the mitral. It can be both done in the septal as well as in the lateral. So since the velocity of the tissue is not as high as that of the blood flow, so we need to filter the higher velocities. So for that, we need to employ what is called as a tissue Doppler imaging. So by keeping your sample volume at the base within the 1 centimeter at the insertion of the annulus, then you switch on the TDI, that is tissue Doppler imaging mode. then you record your this annulus velocity, movement of the annulus. Okay. So it has to be done on both sides, septal as well as on the lateral side. So when you do that, you get this type of an image. When you compare to the previous waves, this is the annular velocity looks little different. Here you will be seeing so many waves, but the wave that is very important for us is the negative wave, and that too the first wave, that is E dash. So in the last slide, that is your inflow pattern, we have seen the waves were coming in the positive direction, and the first wave is E, the second one is A. We were analyzing the ratio between those two. And when you are using the tissue velocity, here we are using the first one. This is E dash. Again, using the caliper, you can find out what is the E dash. Then you get the E by E ratio, E by E dash ratio. So now you have two different values. Okay, normal value is septal. Normally, if the LB pressure is good, then your tissue annulus is going to move further. So the normal values on the septal side will be more than 8, and the lateral side it will be more than 10, and E by E ratio will be less than 8. If it is less than 8, then indicates that pressure in the LA is normal. Okay, how are we going to interpret? So if you see the echo report, the comprehensive echo report sent by the cardiologist, you see the grade 1 diastolic dysfunction or grade 2 diastolic dysfunction, grade 2. What exactly is the meaning of that grade 1 and grade 2? So we have seen how these two waves are formed by mitral inflow patterns. So normal is always E is taller than the A. So the ratio will be always between 0.8 to 1.5. But when the patient starts developing the problem with the relaxation, remember that first the diastolic dysfunction starts with the problems with the relaxation of the left ventricle. So what happens? Your E is smaller and A becomes taller. So if the E is smaller than the A, then it's called as grade 1 diastolic dysfunction. As it takes more time for the atrium to empty into the left ventricle, the deceleration time also becomes more. So normal deceleration time is 160 to 200, whereas in the grade 1 diastolic dysfunction, it goes about 200. Okay. So then what happens? Your left atrial pressure starts to compensate. So the left atrial pressures also start increasing. Then again, for a short time, the your E and A wave looks like or not become, it will look like a normal. If you see these two, the normal and the grade 2, the pattern is more or less same. It's called pseudo normalization. So now you can ask me that if you get a wave like this, how do we know that it is a pseudo normal or normal? So for that, we need to do we are having some other parameters. For an example, a patient of aged more than 45, or the patient who has got already the systolic function is compromised, or the presence of hypertension. These are all the certain parameters which will tell you that this pattern is not normal. But the objective finding is you have to assess the E by E dash ratio. That is where our E by E dash, the tissue annular velocity, comes into picture. If the E by E dash is higher than, I already told you, the higher than 15, then if it is high, then it is considered as that's not normal, it is pseudo-normal. As the situation worsens, LA pressure starts going up and E becomes taller and taller, and then E exceeds more than 2 times. The ratio becomes more than 2. For some time in the beginning, it will be reversible. That is, any maneuver that is going to unload the heart. For an example, your Valsalva, it is going to reverse to the previous one. For an example, if you see a pattern of grade 3, and if you ask the patient to do a Valsalva, then E by A becomes normal, something like a pseudo-normal. Then it becomes reversible. Then finally, it reaches a state where even the unloading maneuvers that is causing unloading also cannot reverse it back. So it's called non-reversible or irreversible pattern. So for our perioperative period, if you see any patient who is coming into the grade 4, you have to be very, very careful about your fluid strategies. That's the most important part of the diastolic assessment of the diastolic dysfunction. So these are all the certain markers where you can know that where your LA pressures are very high. As already told, basically a grade 4 diastolic dysfunction. If the E by A is more than 2, or the DCT is less than 160 meter per second, and then your E by E ratio is, if it is on the median, that is septal, if it is more than 15, or E by E dash is more than 10 in the lateral. Is it possible to calculate the LAP with available? Yes, it's still possible. There are certain formulas which are available in the textbooks. You can just go there. But what that you need to know this E by E dash. This is the importance of calculating this, the diastolic function indices. Okay, that's about the diastolic function assessment. Then we'll go to our next topic, that is your regional wall motion abnormalities. I'm sure that every one of you will agree with me that this is the one area where we concentrate a lot. Because to know whether the patient has got a regional wall motion, it's always impractical to get the assessment for all the patients. But and also sometimes when the patient comes to us without a proper echocardiogram, we'll always in a dilemma whether the patient gives the history of some vague cardiac abnormality. Sometimes they'll say that 2 years back I was hospitalized for some cardiac problem, and we are not very sure. The ECG will not give you much information. And at that time, if you know how to pick up this regional wall motion abnormality, it will come very handy, because we know that it's one of the major risk factor for determining the perioperative outcome. So that, and also we can stratify the risk, and also we can plan our anesthetic management accordingly. And also in the perioperative period, if this patient shows signs of this regional wall motion abnormalities, we know how to proceed further. So how are we going to analyze this? So this you would have seen in all the textbooks. Traditionally, your left ventricular wall is divided into 17 segments, which we are not, as a bedside tool, we are not going into much of the detail. But what is more important is this particular view, that is your mid-papillary view, which we have already seen in the last session. So this will tell you by analyzing this particular view and seeing how all the segments are moving, that will give us a reasonable amount of information regarding the wall motion abnormalities. Because this is the area which receives the blood supply from all 3 coronary arteries. So this is the view we need to get. That's number 1. And also the apical 4-chamber. This view also will give you information regarding this regional wall motion abnormalities. Okay, let's see. These are the 2 things which I was talking, 2 views which I was talking about. So how are we going to analyze this? Okay, so what do you mean by the regional wall motion abnormalities? So we know that the left ventricle contracts in a circular fashion. That means during the systole, and all the walls, that all the segments of the left ventricular wall should move inwards. That is the normal. That's what is endocardial motion. And the wall thickness, remember that last time when I was talking about the assessment of the systolic function, I told you during the systolic time, and the wall should get thickened. And if it should be about more than 40%. That's considered as the norm. In case if there is any abnormality, if the movement is not as we expect, one particular segment is not moving, or the wall is not getting thickened during the systolic time, then it's called hypokinesis. Then akinesis is, as the name implies, there is no movement of that particular segment, and wall is not, the thickening of the wall is not happening. The dyskinesis is totally different. That not only it doesn't move, in fact, it moves outside during the systolic time. Systolic, instead of coming towards the center, it's just going outward, and the wall becomes thinned. It's called dyskinesis. And if the dyskinesis is permanent and it's an aneurysmal deformity. This is what, once you know this nomenclature, then you can find out how to analyze how to pick up the regional wall motion abnormalities. And this is a just graphical representation of how each coronary is supplying the walls. Okay. So just let me show an example. So can you say this? This is a, you know that, what is this view? This is an apical, this is a mid-papillary view, where you see the segment of the left ventricle, and you see both the papillary, the anterior as well as the posterior papillary muscle. But if you see this particular area, this area is not properly, just go back, I'll go back and I'll come to this slide again. So if you can you notice the improper movements of this particular segment? So if you see image or the clip like this, then it tells you that this segment, especially this segment. So once if you know the territory supplying this particular vessel, particular wall segment, then we know which particular artery is occluded or is not, the supply is not adequate. Okay. So then the third thing is how to assess the RV function. So we have been talking about, or we have been seeing the assessment of the left ventricular function. Why do you think this assessment of RV function also is important? That I'll show you certain in the videos later. So we know that the anatomically and physiologically, the RV is different from left ventricle. So because the left ventricle is somewhat is an ellipsoidal or circular, then RV is concentric. This is very important. Then physiologically, at any point of the time, the pressure within the left ventricle is much more than the right. As a result, septum is always pushed into the RV. So that causes that, or that makes this left ventricle circular and RV as a concentric. This is it normal. So what we need to know is, for some reason, if this RV is not functioning properly, or if the right ventricular failure where the pressure starts going up, or end diastolic or diastolic pressure in the RV is going up, that's going to cause a dilatation of the RV. As a result, this septum will be pushed into the left ventricle. So if we are able to pick up that one, then we know that RV is not functioning properly. So how are we going to? So what are all the parameters, or what are all the indices that will tell you that RV is not functioning? Here, unlike where we are going to quantitatively assess the left ventricular assessment, here we are not assessing the RV function. In fact, we are picking up whether RV dysfunction is there or not. That is ruling in or ruling out of RV dysfunction. So for a focused or a goal-directed echocardiogram, that is what is required. That is, we have to know whether the RV dysfunction is there or not. How are we going to do this? The first thing is very simple. That is called TAPSE. That is tricuspid annular plane systolic excursion. That will tell you about how the RV is moving in the longitudinal. We know that we have been discussing about the left ventricular motion that comes in the circular motion, whereas the right ventricle moves in the longitudinal motion. So if this TAPSE, that is your tricuspid annular plane systolic excursion, will tell you about the systolic function of the RV, that is in the longitudinal fashion. Then we have the qualitative assessment of RV when compared to LV. So what are all the parameters? I'll tell you later. Then third thing is about the looking at the septal position. Then fourth is the right ventricular systolic pressure estimation. So this right ventricular systolic pressure estimation will tell you about whether there is a pulmonary hypertension is there or not. So let's see one by one. So that to start with the TAPSE, that is your tricuspid annular plane systolic excursion, even though the name is a little bit complicated, it is not that the performing the TAPSE is very simple. You get a good 4-chamber view, then employ the M mode, then the M mode has to pass through the annulus of the tricuspid. And then activate the M mode, you get a pattern like this, and you just with the caliper, you analyze the highest point and between the lowest point. This tell you how much the tricuspid annulus is moving, because since it's attached with the RV, it moves longitudinally. So anything above 17 is considered as normal. So if this TAPSE is less than 17, then we know that right ventricle is not moving properly. So that tells you that that's one of the indicator for right ventricular assessment of, or rather the right ventricular dysfunction. We'll move on to the next one. So how do you qualitatively assess the right ventricle and the left ventricle? It's done with a comparison. So we all know that the apex of the heart is formed by the left ventricle. That's number one. Number two, always left ventricle is bigger than that of the right ventricle. So if in case of right ventricular dysfunction, what happens is this gets reversed. So as a result, the apex will be formed by the right ventricle, and also the ratio between the right ventricle and left ventricle is reversed. For that matter, if the ratio is normal, equal, that is, if the RV is equal to that side of the LV, then you can say that there is a problem with the RV. So by looking at a good apical 4-chamber view, you will be able to pick up that. The third thing is septal position, which I already told you. So during both diastolic and systolic time, your left ventricular in the mid papillary view, it should be a proper circular view. So if that, you know that this is right ventricle, this is the left ventricle. if the pressure in the right atrium goes high, what happens? This pushes the septum down into the left ventricle. So you know, or you'll be getting what is this? What called as D-shaped septum. So this D-shaped septum tells you that pressure on the right ventricular side is a little bit on the height, and there are measures by which you can find out whether it's a chronic or acute. And a chronic, if the right ventricular wall is thickened than more than 5 millimeter, then we know that it is it's a chronic. Then we not be worried about that. But suddenly, if it happens that in the beginning you don't see a D-shaped septum, and suddenly in the middle of the surgery you start seeing a D-shaped septum, then you know that you are into trouble. So then the estimation of your right ventricular systolic pressure. What are we going to do this? So we need to understand, or this concept is very important to how to know how to estimate the right ventricular systolic pressure. So this is IVC, this is the right atrium, this is the right ventricle, then you have the main pulmonary artery, then it goes to the right and left. So if you want to measure the pulmonary artery pressure, we know that if the valve, it's a pulmonary valve, if it is not stenosed, if you are able to measure the right ventricular pressure, then it's equivalent to the it's a surrogate marker of your pulmonary pressure. That's point number one. So if you know what is the pressure at the right atrium, and then if you add the pressure gradient between this right atrium and right ventricle, then that tells you that the RV pressure, correct? So if you add pressure gradient with the right atrial pressure, then that tells you for the right ventricular systolic pressure. Okay. So for this, how do you measure the pressure gradient? So for that, we take the concept of what is called as our Bernoulli's theorem. So based on this, we know that the pressure can be obtained by your 4 into v squared, that velocity. What velocity? Here we are calculating the velocity of the tricuspid regurgitant jet. So that is, if the jet that is coming back into the right atrium from the right ventricle, that's the pressure gradient. If you can measure this velocity, then using this formula and then adding the estimated RA pressure, you can come to a conclusion about the right ventricular systolic pressure. Okay. So then another thing is, how do we know that this, what is the RA pressure? So either if you have a CVP, that will tell you the RA pressure. Okay. Nowadays we are not using the CVP for just for the purpose of calculating the pressures. So then we can go for this formula. That is, you can do an analysis of the IVC. If the IVC is less than 2.1 and the collapsibility is more than 50%, then we take the RA pressure is somewhere around 5. Then if it is just based on this formula, this is available in the textbook. So you know that what is the RA pressure, whether it's 8 or 15. So by using this formula, you can get the right ventricular systolic pressure can be calculated. Let me show you an example how to do that. The first thing is you have to get a good apical 4-chamber view. Then use the color Doppler at the tricuspid level and then find out the jet. Then you apply this continuous waveform. So I told you that last time while analyzing the mitral inflow patterns, we were using the pulse wave Doppler. Here, whenever the velocity is, you assume that velocity is very high, especially when it is passing through a valve where the turbulent flow is formed. There you have to use your continuous waveform. So use the continuous Doppler, then measure the pressure gradient, then add the RA pressure from the IVC view, so that your right ventricular systolic pressure will be this. Let me show this. So we know that in this right ventricle is enlarged than the left ventricle. So we know that there is a problem. So we of the right ventricular side. So now we want to analyze the right ventricular systolic pressure. This is the tricuspid jet. So if it is this, if that equal sign is there, that is your pulse wave Doppler. If the diamond shape, it's a continuous Doppler. So locate the flow at the jet, tricuspid jet. Then you will get a wave like this. This is the tricuspid regurgitant jet. So qualitatively, if you see a significant jet like this, then you can be very sure that very well sure that the PA pressure is elevated. You can stop there, or for you are very particular. I just want to know what exactly is the PA pressure. Then you can go for measuring. So what you can do is, once you get a waveform, then take a good waveform. Then using the calculation package, you measure the tricuspid regurgitant TR jet maximum of. So automatically the machine will tell you, calculate you can look at this right ventricular systolic pressure is around 70. So you can very well know that this patient has got pulmonary hypertension. So by analyzing the right ventricle, So number one, you can analyze their systolic function by utilizing the TAPC. Then in case of acute RV failure, you can analyze by locating by comparing the right ventricle to that of the left ventricle, and also looking into the septal position. Then third, in case of pulmonary hypertension, you can estimate the pulmonary pressure in the right ventricular side. Okay. So with that, we will move on to the next session, that is about how to pick up the significant valvular lesion. Here we are not worried about the very mild or a very trivial valvular lesion, because the lesion which is going to alternate or compromise or impact our anesthetic outcome, perioperative outcome, that is what we are worried. And we know that most of the time the left ventricular lesion only will give us trouble. So how to pick up the left ventricular, left-sided significant lesion, especially the stenotic and the lesion, and also regurgitant lesions. So we'll see how the mitral stenosis, aortic stenosis, regurgitation of the mitral and aortic valve looks. So the image, by looking at the image, you know that this is a plaques view. This is the aortic valve, it's opened. And so this is in systolic phase, left atrium and left ventricle. Your mitral valve is in closed position because this image is taken during the diastole. So in the books, you would have read the features of what are the echocardiograph features of mitral stenosis. You would have seen the hockey stick appearance, candle flame, and thickened commissural fusion, thickened chordae. So all these things can be seen in this. So if you recollect my previous images where this anterior leaflet of the mitral valve is moving very well and it is going and touching the interventricular septum. That's what we have seen and during the assessment of the systolic function. But if you see in this video, so because of this fusion, the tip of the mitral valve is not moving well. As a result, what do you get? Something like a doming. This is called diastolic doming. And this is what is your hockey stick appearance. Okay. Then you can see the thickened chordae and the thickened leaflet. We'll go to the next view. This is your short axis view. You can see the mitral valve opening, and it is not opening completely like a normal opening. So once you see this type of opening, then you know that it is not normal. And this mitral valve is because of the fused commissure, it's not able to open. This is what called a fish mouth appearance. You would have read it in the textbooks, fish mouth appearance. Okay. Then because of the fused valves, leaflets, there is a turbulent flow is developed here. As a result, you get this type of a mosaic pattern, and this is called candle flame appearance of the mitral stenosis. So if you are able to pick up this, you know that this patient has got a mitral stenosis, and we know that the next step is to assess the severity. As we all know, the two things. What will you do next is assessment of the severity, and to assess the severity, we need to know what is the area, because our classification is based on the area. Number one, then of course your pressure gradient. How it can be done, how you can assess the severe mitral valve area. There are two methods by which we use. Even though there are three methods, this EF slope, we are not following it because this is not proven beyond doubt that this tells you about the severity. So we follow these two methods, the planimetry and Doppler based. See, both methods we have been using in ultrasound earlier also, so it is not very difficult. So what you need to do is we just get this view, the fish mouth appearance view. Then freeze the image at the widest part of the opening. That's here the mid diastole. Then you, with a caliper, just analyze. This will immediately will give you the mitral valve. So once you know that, you know about the severity, whether it is more than 2 or it is less than 1.5, less than 1 or 0.75. So based on that, you can assess your. This is called planimetry method. Sometimes it's very difficult to get this image, or you will not be able to trace the opening properly because you need to get multiple images. Or if the valves are calcified, you will not be able to get this nice image. So as a result, what happens? You need to use the different method. So for that, we need to know what is the pressure of time. So again, the terminology is very big and little confusing. It's nothing but how much time for the transmitral pressure gradient to become half of that. That's all. That's what is pressure of time. So how are we going to analyze? You remember that when I was talking about the assessment of the diastolic function, this is what I told you. This is what the image we got. So the first one, the mitral inflow pattern, you get a E wave, and this is the A wave, correct? So you are analyzing the E. Then once the E is assessed, then automatically something called a PHT. This is called pressure of time. So the pressure of time traces the ramp, this ramp particularly, how quickly or how slowly the flow goes down. Okay, like this. So if this is going to be, the angle is going to be like this, then it tells you that the patient's pressure of time is very high, and there is a, because it takes long time for the LA to get empty. That's because of your stenosed valve. So by analyzing the pressure of time, then we know what is the mitral valve area. How to do that? Here comes the pressure of time. Then there is a standard formula, that is your 220 divided by the mitral valve area is a standard formula. 220 divided by your pressure of time will give you the mitral valve area. This is more standard than your planimetry. So if this is 108, you take it as somewhere around 2 centimeters squared. So we know that we are not dealing with in this particular patient, we are not dealing with severe mitral stenosis. So we can plan your anesthetic management accordingly. Okay. So next step is to looking for the complication. So we know the severity, then also we need to find out whether there is we know that obviously that mitral complication, that most important complication is the atrial fibrillation. Then what we are going to do? So we know that by looking at the plaques, you know that the patient has got some sort of an arrhythmia. We are not very sure what type of this arrhythmia because it's not contracting regularly. So what are we going to do this? Again, we'll come back. This is your short axis view, the same patient, mitral stenotic patient. Then we'll come back to the next. So again, the mitral assessment of the mitral inflow patterns. Here, normally we were getting, as I was telling a little earlier, then when you analyze the mitral valve inflow patterns, we get two waves, correct? The first wave is E, the second wave is A. So in case of atrial fibrillation, you know that your atrial contraction is lost. So that's obvious. No, that's every one of us know. So when this atrial contraction is lost, what happens? The second wave, that is an active A wave, is not produced. So when you do a mitral inflow pattern study, and if you see only one wave and in this irregular, then you know that we are dealing with the patient of mitral stenosis along with the atrial fibrillation. Okay, so that will tell you whether this patient has got an atrial fibrillation or not. Then, of course, for the pulmonary hypertension, which I have already discussed, how to calculate this, and at the end, you know that this patient has got whether the patient is in the sinus rhythm or this patient, and also whether the pulmonary pressures are elevated or not. Then next, move on to the next regurgitation, that is your mitral regurgitation. It's nothing but just picking up the color flow. This is enough for the initial study. So we know that this is a mitral valve, and during the diastole, the flow happens inside. So during the systole, there should not be any backward flow into the left atrium. That's correct. So if there is a flow into the left atrium during the systole, then it should tells you that your mitral valve is incompetent as there is a mitral regurgitation. And also this enlarged left atrium will give you a clue regarding that. You can see during the closure, you can just the jet is coming back into the left atrium. That tells you that there is a. Of course, previously we were following. Oh, okay. Next step is how to assess the severity. Previously, we used to assess that how long this jet goes and touches the left atrium. But again, there are some controversies whether about whether we can assess the severity based on this particular observatory method. That results are not beyond doubt. So what we can, there are other parameters to assess the mitral regurgitant severity. Either if the E velocity is more than 1.2 meters second, or the very much reduced deceleration time. This all tell you about the severity of the regurgitant. And also, in case if you want, you can calculate the regurgitant volume also. I'll be talking about subsequently how to calculate the stroke volume of the left ventricle. If the same concept is used for calculation of the stroke volume of the left atrium, then if you detect the stroke volume of the left ventricle, that means that amount of blood has gone back into the left atrium. That's logical, correct? So if you can do that, then even you can pick up the regurgitant volume also. Then you can analyze the severity of the mitral regurgitation. And okay, the third important, this most important thing which we know that you hear a murmur and you are not very sure whether it is a early systolic or rejection systolic or a mid systolic, and but you want to rule out. It's the middle of the night, you get a patient for an emergency surgery and you want to rule out aortic stenosis. You're not very sure whether to go ahead with regional anesthesia or should we induce the patient. So at that time, if you know how to rule out aortic stenosis, then it comes very, very very, very handy, and it will be helpful to you. The first thing is just as the looking of the aortic valve, you can come to a sort of a reasonable conclusion. In this, you see during the diastole, the aortic valve is closed like this. It's a clasp sign, like folding of the hand. And during the systole, it just opens nice. So when you have your image is like this, then you can be reasonably sure that this patient will not have aortic stenosis. Even if it will not have any hemodynamic impact in the perioperative period. So this is what is, but at the same time, if you get a valve like this in the plaques view, then with a thickened valve, that should raise a suspicion that this is a calcified aortic valve. That should raise a suspicion that whether this, is there a possibility that this patient has got an aortic stenosis or not. So how are we going to do this? For this, you need to do a simple Doppler study. Nothing but we get a apical 5-chamber view. You know how to get an apical 5-chamber view. Then you take a continuous wave Doppler and keep it at the aortic root level. Then activate the CWD. Then you get a negative waves like this. This is the jet, your LV jet into the aorta. And if you can measure the velocity, if the with this velocity, the maximal velocity is more than 250, then it is suggestive of aortic stenosis. So we have read in the textbooks that if the velocity, based on the velocity, we are going to grade the assessment, aortic stenosis severity. If it starts from more than 250, this is how we have to analyze, or if you have to measure. So based on this, we know if the velocity is more than 4, then we know that there is 400 centimeter per second, then it is very severe. And in between is a moderate AS. Just let me show you an example. So this is you get a good A4 chamber, A5 chamber, then there's a continuous Doppler. It's kept at the aortic valve. Then you get a activate that, you get a wave like this. Once you get a nice jet, freeze that and go to the calculation. Aortic valve, then you measure the maximal velocity. So in this particular patient, the maximal velocity comes somewhere around 558, which is much more higher than the 200. That means this patient has got a very severe aortic stenosis. So then once you know that this patient has got a severe aortic stenosis, then you know how to manage, what type of anesthetic management is suitable for this particular patient. So this assessment of or analyzing the pressure gradient, the velocity, velocity is very, very helpful for you to differentiate the aortic stenosis severity. Okay. So the shape of the curve also will give you an idea whether this is severe or not. If you get a nice rounded curve, that means the obstruction is very severe, because in severe obstruction, the obstruction comes little late. But whereas the peak is little bit earlier, that tells you its obstruction is very mild. So by looking at the curve itself, we can just find out whether the assessment, the aortic stenosis severity is severe or it's a mild to moderate. Okay. Then the next one is the aortic regurgitation. Just like the mitral regurgitation, here we need to pick up this the mosaic pattern. That is, whenever there is a there is a turbulent flow, your blue and red mixes together and produces the this mosaic pattern. Okay, you are able to see during the diastolic time when the mitral valve is opening, you get a backward flow from the aortic valve into the left. So that tells you that this patient has got an aortic regurgitation. So how are we going to analyze or assess the severity of aortic regurgitation? So if you can hear, what we need to know is how much this jet occupies the LVOT area. So whether it is occupying the 25% or more than 50% or more than 75%, that based on that we can analyze the severity. If it is occupying this is the LVOT. So if it is occupying less than 25%, then it is mild, and if it is going beyond 65, then it is considered as severe aortic regurgitation. So this all information will give you, this is not the I mean, this gives you an idea. So whether this patient needs a further consultation by the cardiologist, or still you can go ahead with the surgery. That's where this information is going to be helpful. I'm not telling that once you know that you don't send the patient to the cardiologist. It's not like that. So in case of an emergency where you have to make a decision, so based on that you don't get any help, or you're not in a position to get a cardiology help immediately, then these are the, if you know all this information, that's going to be very helpful and handy for you. Then comes the last part of the session, that is your calculation of the stroke volume. So this may not be much helpful for the perioperative period unless the patient becomes, the postoperative period, the patient becomes very sick, but it's very helpful in the ICU. So where we need to know the stroke volume, and to know why we need to know the stroke volume of the left ventricle, we want to know whether this patient, if there is a fluid responsiveness or not. That's the main idea. So by giving the fluids, are we going to improve the stroke volume? In what level of the Frank-Starling curve this patient left ventricle is positioned? That's what exactly we would like to know. So how are we going to calculate the stroke volume? So what are the concept? The cardiac output. This this formula. So what is this view? This is the Plaque's view, and this is the LVOT. So here we are going to calculate the how much blood flow is getting ejected out of this area for each cardiac, each contraction. Correct? That's what is the stroke volume. So assume that this is something like a cylindrical position, because this is something like a cylinder. So if you calculate the area and also the length, the time taken for the blood to get ejected, if you know these two parameters, then you can calculate the volume of the cylinder, which is equivalent to the stroke volume. Volume of the cylinder is equivalent to the amount of blood that is coming out of this. So to that, what are we going to do? So we know how to calculate the volume of the cylinder is pi r squared multiplied by the height. So here, instead of the cylinder lies like this, so height becomes this becomes the height. So this is nothing but the RBCs have to travel over a period of time. So if you can calculate this velocity over the time and also the cross section, that's your diameter, then you will be able to calculate the stroke volume. This is the concept. So what are we going to do this? The time is velocity over time is known as velocity time interval. This is the one measurement which we need to do. So what are the views we need to get? These are the two views. One is the Plaque's view. So where we need to measure the LVOT diameter at the when the valves are well opened. So obtain a good Plaque's view, identify the LVOT, then use the zoom and then measure the LVOT diameter. Okay. So then you go to the apical 5-chamber view, then place your pulse wave Doppler cursor here just beyond or into the beyond the mitral, aortic valve opening. Then you activate the this is of your position. This is the aortic valve, this is the aortic root, this is the LVOT. So you should not, the sample volume should not include the aortic valve. So you get a wave like this. This is the VTI wave. Then you have the package. You got to just wrap around the this wave, and that will tell you about the VTI. So sometimes just by instead of calculating the stroke volume, by looking at the VTI itself, you know whether this patient will respond, the stroke volume is adequate or not. The normal VTI is somewhere between 18 to 20. So that means you know that this patient has got a stroke volume of normal stroke volume. Sometimes if the cardiac output is very in the patient with hypotension, if the stroke volume is less or rather the VTI is very low, then we know that the hypotension is because of the low stroke volume. Where you can differentiate a cardiogenic shock from the septic shock, where in the septic shock your stroke volume is going to be normal, and if the cardiogenic shock your stroke volume is going to be less. So that information also you can get to that. So to assess the fluid responsiveness, what are we going to do here? So if you give a small bolus, something like a 50 ml, and if your VTI is going to increase by 15%, then we know that this patient will respond to the fluids. Or instead of giving fluid, even if you are worried that this even the 50 ml will cause some problem, you can do a passive leg rest test and then analyze the VTI. If the VTI is increasing by 12%, then we know these patients are fluid responders. Okay, but certain things while performing this test, certain things you need to remember. The alignment of the septum and placement of the cursor are the most critical, because the waveform has a beam. The Doppler thing, a signal has to be parallel with the flow. So unless the septum is aligned properly, the value will be either underestimated or overestimated. That's the most important. This is a normal BTA values which I was talking about. And the another thing is each time we need not measure the LVOT diameter. So because as long as this particular patient is there with you, the LVOT diameter is not going to change. So once if you make a measurement, that is enough. So every time you have to do only the VTA measurement, then you calculate the stroke volume. And if sometimes if you are not, LVOT is not, views are not very clear and you are not getting a proper plaques view and LVOT diameter measurement is a problematic one, then you can approximate value is 2 centimeter in adult male and 1.8 centimeter is the adult female. That's an arbitrary value where you can take it into consideration. Okay. So, okay. So having said all the things, so now we have got a lot of information. So how to use it clinically when somebody is, some patient is deteriorating. You don't know whether it is a problem is with the cardiogenny, I mean, at the entry level, or is it because of the right ventricular failure, or it's because of the left ventricular failure. So, or it's because of the obstructive shock. So how are we going to analyze this? So there are a lot of protocols. You would have seen the rush protocol, the FATE, falls. So many things are there. There is one simple protocol, SIMPLB. Then I feel this there is something like a 5E approach. This 5E approach is some sort of a very handful, user-friendly. Whatever views and information which we have talked, it can be utilized into this. So first thing is, first E is effusion. Just use the subcostal view and to know, is there a pericardial effusion, and then you to know whether this effusion is causing tamponade or not. The tamponade, in case if the tamponade is there, there will be going to be a diastolic displacement of the right ventricle or right ventricle into the, that's called collapse of the right ventricle or right atrium during the diastole. If that sign is there, then it's that is a cardiac tamponade. So first E is to pick up the effusion is there or not. The second thing is the ejection. In other words, we are assessing the systolic function, which I already told you how to assess the systolic function. The third is the equality. This is for basically right ventricle. You just look at the shape of the right ventricle and left ventricle and compare. If the right ventricle is bigger than the left ventricle, then you know this patient, this hemodynamic instability is because of the right ventricular dysfunction and maybe because of the pulmonary embolism or so many things which depending upon your situation. The fourth thing is exit. That is, you look at the exit point is nothing but your aortic valve and will be voting. Then look at if there is a problem, whether there is a valvular lesion is there or not, aortic stenosis is there or not, or is there a problem with the dissection of the aortic flap is there or not. So looking at this, you know that what is the cause for this hemodynamic instability. Then 5 is your entrance. Just look at the IVC, whether the IVC collapsed. If there is no collapsed, IVC will tell you that the patient is in a hypovolemic shock or some other reason. If there is a thrombus like this, then we know that this is when it is associated with the plethoric IVC as well as the RV is enlarged, then we know that you are dealing with the patient of pulmonary embolism. Okay, so with that, I will conclude. Sir, can I run some few, do we have time to run few videos? Then we can ask our viewers to respond.
Okay,
That time is there?
Yeah, you can proceed.
Okay. So now what I'm going to tell you thing is, I'm going to show you some videos. You can just send the comment in the chat box. Okay. Just first you need to tell me what is this view and what is the abnormality in this. So how do I know the chat? Okay. Are you able to see the views, sir?
Yes, sir. You can see the answers in the chat box. They are typing. They are posting.
They are posting. If I open the chat box, my video is stopping.
Oh, okay, sir. So they say it's a plaques view.
Very good. It's a parasternal long axis view. Very good. Okay, we'll go to the same patient. We are going to the next. What is this view? What is this view? Are they answering?
Yeah, sir. We have.
Video is playing.
Yes, sir. Video is playing. There is no answer. Chat box.
Yes.
Papillary view.
Very good. Mid papillary view and the short axis. What is the abnormality in this? So maybe the next, it's all same patient's video. Maybe the next video you'll be able to pick up the next one.
So video not playing. Okay, not playing.
So next one. Let's go to the next one.
Yes.
Okay. So are you able to find out the abnormality by this time? What is this view and what is the abnormality in this? What is the view?
Typical 4-chamber view.
Okay. Yes. Good. What is the? I open the chat box. Actually, the video is not.
Video is stopping. Typed as tamponade.
No. So you see, I told you that to assess the systolic function, you need to look at how the chamber size, how it is changing. So the same concept, use it here. We know that what is the chamber size? That there is not much between your systolic and diastolic. That means your left ventricle is empty. And if you see the previous one, your papillary muscles are getting approximated. It's called kissing papillary sign. Your papillary muscles are getting, because of the hypovolemia, they are coming and approximating each other. This is called kissing papillary sign. So this patient, you need more and more for it. Maybe the next one, everyone will be able to find out. The same patient, we are trying to get an information about from the IVC. IVC, is it distended or is it collapsed?
It's collapsed.
Collapsed. And what is the collapsibility? Is it more than 50% or not? It is more than 50%, correct? What is the answer, sir?
So it's collapsed.
Collapsed. So we know that this patient needs more fluid. In case if this patient comes with the severe hypotension, and we can be very well sure that this patient needs fluids, not vasopressor. Okay. So we'll move on to the next one. What is the view and what is the abnormality? What information we are getting, sir?
Yeah, they are taking their time, sir.
Okay. Can I have another 5 minutes, sir? Just finish this.
Okay, okay. You can proceed, sir. They don't.
Okay. So basically, this is an A5C view, apical 5-chamber view. This is the left ventricle, and this is the right ventricle. This patient is your pressures are low. Patient is hemodynamically unstable. So when we did the echo, this is what we have found. You see, the right ventricle is it bigger than the left ventricle? Yes. Yes. Is bigger than the. So we know that this patient has got an acute right ventricular failure. Okay. So now, if you see this, there is something called. Have you read about McConnell sign? So where your right ventricular apex is hyperdynamic, and your basal and the mid and basal will be hypokinetic. This is what is the McConnell sign, which is the specific of pulmonary embolism. So when you have a patient like this, and the patient is hemodynamically unstable, and you can be very sure that this hemodynamic instability is because of the pulmonary embolism. Then by looking at the other one, what is this? Other views. So mid-papillary view from the subcostal. It's not the typical short axis view. This is a subcostal. You can see the liver here. So because of the RV, the pressure at RV is very high. We were getting the D-shaped septum. That's pushing the septum into the. This further confirms the your. Okay. Go to the next one. So you go to the next E. That is your entrance.
Sir, sorry to interrupt. What did you say? What did you tell now, sir? What shaped septum? Can you just repeat that, sir?
D.
Okay. Okay, sir. Thank you. Thank you.
So this is the. So whenever the patient's RV is dilated, RV failure, the pressure is very high. It is transmitted back to the circulation, and you'll have a plethoric IVC. That's what we wanted to confirm. But at the same time, we came to know that we have found that one of the clots sitting here and trying to get into the circulation. So this clearly proven the diagnosis of pulmonary embolism. Okay, that's about one. We'll come to another one more. The time permits one more. Okay. So what is this? This is not exactly what we are trying to find out. The finding is the different one. So this is an apical four-chamber view. Maybe the next video will be very. Oh, so if you see, there is a regional wall motion abnormality at the apical level. So apex is enlarged and it is not moving well. You see this part, and there is an aneurysm in this. So this is one of the preoperative echocardiogram what we have seen. This patient came. We had a suspicion because of the ECG changes, and the patient gave a very vague history. Then when we did the echo, then we found out that this is a apical aneurysm, which we are always reading about in the textbooks. Then this one. This is again about the regional wall motion abnormality, where your lateral wall is moving reasonably well, but there is hardly any movement on the septum. Okay. So this is your fifth E, where you can see the flap. It's a dissecting aortic thing, and there is a. Then where you can see the instead of not only the aortic valve, you can see a small flap coming and going. That tells you about the dissecting. Okay. So with that, I think the time is up. Thank you very much, sir. Any queries? I'll be able to. I'm happy to.
Sir, there is 2 questions in the chat box.
Yes, sir.
First question is, what are the common cardiac conditions that cause diastolic dysfunction?
So diastolic, that's usually whenever that is your impaired relaxation. Basically, when the left ventricle becomes more and more stiffer, it is causing. The commonest one will be your hypertension, long-standing hypertension. Then other connective disorder, or simple aging itself. As we start aging, our diastolic function gets. The commonest cause will be the long-standing hypertension.
Yes, sir. So what precautions you have to take for grade 1, grade 2 diastolic dysfunction during anesthesia? And subsequent question is, in grade 3 and grade 4 diastolic dysfunction, can this patient be operated in a peripheral hospital, or it should be referred to a tertiary hospital?
Okay. So again, it depends on basically why we want to assess the diastolic dysfunction. Basically, we want to plan our diastolic, the fluid optimization, fluid strategy. So in case if you are going to give uncontrolled, if the patient goes into state of volume overload, it is going to cause a systolic dysfunction. That is the reason. So depending upon what type of surgery and what are the other facilities available, you can take a call. So for an example, a grade 3 diastolic dysfunction, the patient is coming for not a very major surgery where the fluid shifts are not there. You're not going to administer too much of fluid, then there should not be a call. But where you have to be very careful that if this patient develops a hypovolemia, then how to analyze how much fluid to be given. So if you know, if you are still the patient is during the surgery, still the patient is in the same sort of type of the diastolic dysfunction, then you are not. For an example, a grade 2 diastolic dysfunction is becoming grade 3, then you have to be very careful that this patient may end in the maybe developing the pulmonary edema, and subsequently you need to treat them. So depending upon the, basically we are assessing this, how much fluid we are going to give. So depending upon your facilities available, you can plan your anesthetic.
Okay, sir. It's my question. That is, in diastolic dysfunction, can we do a fluid challenge test, sir?
Yeah, there's something called a false protocol. That is your fluid administration limited by this. I'm not getting that. The false protocol. What does it say is actually you assess the diastolic function, and also you do the lung ultrasound. Okay, so limited by lung ultrasound. That's a false FALLS. That's a lung sonography. So you keep giving fluids. You assess the diastolic function, whether the diastolic function is becoming from grade 2 grade 3, and you do a lung ultrasound. You see whether B lines are developing or not. Till the time you give fluids. Once your diastolic function is going to the next category, then you have to be very careful about giving. But that means that's the place where the patient may develop the next may go into the overt failure. That's what. So based on the diastolic dysfunction grading, yes, still you can do a fluid challenge.
Okay, so what is the safe limit of giving fluid challenge, sir? How much volume is safe to begin with?
To begin with, see, for an example, that's where actually we go by the stroke volume calculation. So to begin with, you need to have, if you are measuring, your indices are very precise. For an example, if you are calculating a stroke volume, you can start with the 50 ml.
Oh,
you can start with 50 ml. But where you are going to do a diastolic based on your diastolic function assessment, that 50 ml will not show any changes in the your diastolic function. So you may have to go up to 300 ml, not beyond that. The 250, 300 ml is reasonably a good. That's what my opinion. What do you think?
Yes, sir. Okay.
250, 300 ml. Yes.
So without echo, the safe limit is 100 ml.
If you don't have that, yes.
Yes. So there is one question. What is the difference between hypertrophic cardiomyopathy and diatomic dysfunction?
What is the other one?
Diatomic dysfunction. So it is wrongly typed diastolic dysfunction. Difference between hypertrophic cardiomyopathy and diastolic dysfunction.
No, hypertrophic cardiomyopathy is something like where we are LVOT. The problem is at the LVOT, where during the systolic time, the blood is not getting into the aortic. So whereas diastolic dysfunction is the one with both are different entities. So how the HOCM can be assessed is actually there is something called SAM, that is your the anterior movement of the so where we can analyze the anterior lift after the mitral valve, whether it is going and closing the LVOT at the time of systole. That is what we need to analyze. That can be done by the M mode. You do a good plaques view and take a cut at the anterior lift of the mitral valve. So during the systole, normally the aortic valve will be open and closing. It goes closer to the interventricular septum during the diastole. If same thing is happening during the systole, then you know that this patient has got a sort of a HOCM where you have to be very careful.
So when you say the pericardial effusion is significant, is there any kind of value?
Actually, if you want to measure the effusion amount, so anything more than 0.5 to 1 centimeter is you have to be very careful. But the problem is we don't know whether the patient, for an example, you are getting a trauma patient where you observe pericardial effusion. We are not very sure that effusion is there already. Patient may be a uremic patient or it's a chronic pericardial effusion. So when we have to intervene, that is only if it is going to cause an obstructive shock. Otherwise, we are not going to do. So in case of pericardial effusion, what we need to do is we need to know whether it is causing a tamponade or not. So that's the time we need to intervene. So we need to know how to pick up the tamponade. So what are the signs of tamponade? Usually clinically we talk about this Beck's triad, which is very difficult to follow in the emergency situation. So by doing an echo, we look for what is called as a diastolic collapse of the right atrium. So normally in the diastolic time, the right atrium is distant. Correct? So during the diastolic time, the outside pressure is very high because your cardiac tamponade effusion pressure is very high. It pushes the diastolic, right atrium, wall of the right atrium into the right atrium. So if you see a diastolic collapse, then it is suggestive of the tamponade. If the pressures are when building up, the right ventricle also will start getting collapsed. Okay, that is what, when you see a diastolic collapse of right atrium, right ventricle, then it can be very sure that this is causing a tamponade. You can confirm it with the M mode also, because how do you know that it's a diastolic time? So you need to do a M mode where the mitral valve is open. At the same time, if the right ventricle is getting collapsed, then you can know that that is a diastolic collapse. At that time, we need to unless if the cardiac tamponade is not there, just by the effusion, we need not.
Thank you very much, sir, for an excellent presentation. Dr. Sir Prasad, do you have any questions? Thank you, sir. We will move to the next topic.
Thank you very much, sir. Thank you for the opportunity. I think I've done reasonably.
No, sir. It's an excellent.
Thank you. Thank you.
We will meet the next week with an interesting topic on the dissertations for postgraduates. Thank you. Thank you, Anandal. You can view the continuation of this session in the YouTube. It will be uploaded in the evening.